Great. Thank you. And thank you everyone for joining us. This session is centering Medicaid members' food access and health for better outcomes. We're really excited to bring this to you all today. My name is Greta Allen. My pronouns are she, her, and I'm the policy director at the Colorado Blueprint to End Hunger. We are a statewide anti-hunger and collective impact organization in Colorado. Samantha?
Hi, everyone. I'm Samantha Fields. I am a Medicare and Medicaid member. I am a SNAP recipient, and I am the Connecting Food and Health Project Team Lead at Colorado Blueprint to End Hunger.
Hi, everyone. My name is Tamara Keeney. I am the Research and Analysis Manager at the Colorado Department of Healthcare Policy and Financing. We are the state agency in Colorado who administers Health First Colorado, which is our Medicaid program, as well as the Child Health Plan Plus or CHIP program and other programs that Coloradans can qualify for.
Awesome. All right, let's dive in. So our plan for today is that we'll share a little bit about how we are connecting food and health in Colorado. Then I'm very excited for you all to hear from Samantha and her journey as a member and advocate in this work. We will share our timeline of this advocacy. And I also want to mention that I've uploaded any documents that I could as examples of letters and sign-ons and other forms of advocacy that we used with our Department of Healthcare Policy and Finance. And then we'll share about some future plans for Colorado in this space, as well as all three of our reflections on this work. And then we're hoping to have plenty of time for questions, so please be using the chat or the Q&A feature. I also want to share with everyone that I uploaded a PDF version of these slides. You'll notice that they're bilingual, but there are some slides where we alternate English and Spanish. And so if you would much rather follow along through that PDF, it is uploaded for y'all. So also before we get started, acronyms are a very real thing, I think, for many of us working in this space, particularly when there's federal programs involved and many different departments. So this is some of the language that we'll be using today. We will also make sure that we spell out our acronyms as we're speaking. But again, this is uploaded as part of the PDFs. And so if you want to have this handy while we read, we definitely want to make sure we're using shared language today. The ones that I'm going to call out the most that you'll likely hear, one is HCPF, and that is our Colorado Department of Healthcare Policy and Finance. Also ACC or ACC Phase 3, we will be talking about that a lot. And that's our Accountable Care Collaborative in Colorado, which is essentially how our state manages the care of members of Medicaid. Other than that, the other last one I'll call out is ARRAE or RAE. And these are regional accountable entities. And I'll share a little bit more about what they are in a future slide. But those three, I think, are the best to kind of keep an eye on as we go through today's presentation. So just kicking us off and why we wanted to bring this to you all today and how we're connecting food and health in Colorado. While I'm a policy director, I'm also a registered dietitian, and I do believe that food is medicine. And I also think it's important to recognize that food is health. And so knowing that our state of Colorado is becoming increasingly interested in exploring food as medicine concepts, particularly through our Medicaid program, we, being myself, advocates, other organizations, saw 2023 as an opportunity to start highlighting that we need a foundation of food and nutrition access for all Medicaid members in Colorado before we begin building programs that are more tailored to healthcare. So in 2023, our state began a new RFP process, request for proposals, for the regional accountable entities, or the RAEs. And we could probably do a whole hour on the RAEs, but in a nutshell, the RAEs are responsible for coordinating Medicaid member care in Colorado. They are a managed care-like model. They're not exactly managed care, but they provide the health care and social needs care of the Medicaid members in their region through care coordination and other services. So knowing that this RFP was coming out in our state, the Colorado Blueprint to End Hunger and other statewide advocacy organizations did was meet with HCPF, submit recommendations for how these RFPs could better tie the role of the raise to the food and nutrition access of their Medicaid members. And this included a letter. It also included, like I said, recommendations, which Tamara will share more about. And overall, it was an effective way to draw attention to there are many ways that the raise can work on food and nutrition access. However, in my opinion, we failed in that we did not include Medicaid member voices in that initial reach out. And whether or not the ideas we brought were correct, they needed to be rooted and vetted by those that they were speaking to. And so this is what led to our Connecting Food and Health project team at the Blueprint. So that fall of the same year, the Blueprint co-led the creation of this project team space alongside Samantha and other Medicaid members in order to create a forum and an ability to create a shared narrative around what does food as health mean in Colorado? What does it mean to Medicaid members? What does the Accountable Care Collaborative mean to Medicaid members? And how can we better integrate the raise in our food and nutrition access work? So on this slide are just some of the things we did. We spotlighted existing community-based organizations that are doing food and nutrition work. We were able to get participation from the regional accountable entities to, again, build partnership and shared meaning. And what we also did, which Samantha will speak to more, is encouraging Medicaid members to access existing spaces for them to influence how their care is coordinated in Colorado. And this is through spaces like the MEACs, MACs, and PACs, or member engagement advisory committees, member advisory committees, and performance improvement advisory committees. And overall, what we found is just that providing access to information, knowledge, and power sharing were all really impactful ways to start really building a movement around food as health in Colorado. So I will pass it to Samantha.
Thank you, Greta. Hello, everyone. Thank you for allowing me this time to share my journey as an advocate and the importance of the Connecting Food and Health project team in shaping member spaces and the larger conversation around food access. I've actively been involved in various advocacy efforts for several years. I've been focused on Medicaid, food security, and chronic disease management. Today, I want to walk you through my journey, highlight why Connecting Food and Health has been such a critical initiative for me, and share the impact it has had on our existing member spaces and how it's elevated the conversation around food access in meaningful ways. If you can go to the next slide, Greta. My advocacy journey began with personal experience rooted in challenges I faced with food insecurity, chronic illness, and navigating complex, disjointed healthcare systems. Like many of you, I've experienced firsthand how disconnected these systems can be, where food and health are often treated as separate, despite being completely intertwined. This disconnect was a catalyst for my involvement in advocacy, driving me to join the Colorado Blueprint to End Hunger and continuing my work with the Medicaid Member Experience Advisory Council, the MEAC, also with the Regional Accountable Entities Member Advisory Committee, the MAC, and the Department of Human Services Family Voice Council. Through these spaces, I've had the privilege of working on a wide range of issues, everything from Medicaid policy to food justice and transportation advocacy. A cornerstone of my advocacy work has been my participation in the Wednesday Gang, a small group of Medicaid members who have met weekly for over 4 years now. We've built a close-knit, supportive community. Originally started at the beginning of the pandemic to help members of the Medicaid MEAC stay connected. These meetings quickly evolved into much more. We share advocacy opportunities, we discuss the work we're doing on various committees, and exchange thoughts on gardens, wildlife, and even the squirrels and bunnies in one member's yard. When needed, we also provide personal support for one another. None of us expected these meetings to continue for so long, but the bond we've formed has been natural and powerful. Throughout these discussions, we all agree on one important principle. People receiving the services should have a voice in shaping how these things operate, including sharing what works and what doesn't work. Their insights are crucial for understanding both the strengths and shortcomings of the system. This insight has been foundational to the advocacy work we've done, especially when reflecting on our own experiences with systems that too often feel disconnected and siloed. Next slide, Greta. And this is the Wednesday gang. The four of us have been meeting every Wednesday for 4 years now. And we talk about these issues with food, Medicaid. By consistently gathering as a group, we've had the space to share honest feedback and help shape changes that better serve our community. This consistency has kept me grounded and has allowed me to stay connected to the needs of my community. Across all of this work, one theme remains central: food access. For me, food access isn't just about making sure people eat well. It's about ensuring individuals have the resources they need to manage their health holistically. Whether it's a person struggling with diabetes or another chronic condition, or someone trying to break the cycle of poverty, access to healthy, nutritious food is critical for long-term well-being. It's about treating food as a fundamental part of healthcare, not as a separate concern. Next slide, please. Through Connecting Food and Health, I saw the potential to bridge the gap between prevention and prescription in the food is medicine space. It was the opportunity to start meaningful conversations about how food access directly affects health outcomes, particularly for vulnerable populations like Medicaid members or those living in food deserts. I also saw the project as a way to challenge the status quo and advocate for more holistic integrated solutions. One of the most rewarding aspects of the Connecting Food and Health project team is the collaborative effort. I co-lead the project team alongside Greta, facilitating conversations with community-based organizations, State Department employees like Tamara, regional accountable entity employees, statewide and regional advisory councils, and Medicaid members to share insights on food access and how it affects health outcomes. This knowledge sharing fostered stronger partnerships between Colorado Blueprint to End Hunger, Medicaid spaces, and organizations dedicated to food sovereignty. The work we do isn't just about sharing stories or data. It sparks new conversations that hadn't been elevated before. For instance, we brought to light how Medicaid members managing chronic diseases struggle to access healthy, affordable food, and how this impacted their ability to maintain stable health. By creating space for these discussions, we began to shift the narrative. We moved beyond simply talking about food insecurity as an isolated issue and began addressing it as a critical component of healthcare planning. This project team, such as the Medicaid Member Experience Advisory Council and Member Advisory Committee, and the Family Voice Council. By bringing food access into these conversations, it became clear that food security wasn't just an issue for certain demographics. It affects nearly every member of our community in some way. These members' spaces became platforms for elevating the conversation around food access, pushing it to the forefront of policy discussions. I watched as new, bold ideas emerged around how we could integrate food programs more closely with health systems. And I'll turn it over to Greta here to talk about our timeline.
Awesome. Thank you, Samantha. So as I shared, all of the documents that these stars represent on this timeline were uploaded into the conference platform. And so what I really want to highlight here is that we plugged in as a project team from the beginning and wanted to first and foremost make accessible all the spaces that HICPUF was hosting, as well as creating our own ways of providing input through template letters, comments, and gathering sign-ons, and just creating as many pathways to get member and also the organizations that serve Medicaid members all their feedback directly to HICPUF. And so kind of just going through this timeline, I shared about how we had that original letter and the recommendations document. And then what we did was really publicize as many of the public comment sessions as possible, providing talking points. When folks couldn't attend, I promise you, Samantha went to every single one and brought comments from the project team, putting it into the chat and making sure that HICPUF was able to speak to those questions. And then beginning in 2024, when the draft language came out, it was really important that we made that language accessible. It was a big document, but we went through and identified all the contract language that included nutrition and food access. We made sure that language was translated, and then give our community members the time to give feedback on what from that language needed to be kept, did anything need to be tweaked. And then that was able to inform additional advocacy conversations and public letters that we submitted to the department. One thing that you'll see in the example contract language that I uploaded and other documents is that we really looked at different pieces of how Medicaid members might interact with food and nutrition access. We explicitly call out the SNAP and WIC programs and the importance of integrating those programs access as much as possible with Medicaid. But we also see that the contracts call out partnering with community-based organizations, asking the RAIs not to reinvent the wheel, but rather bring current resourcing that they have to existing spaces where Medicaid members are getting food and getting support. And then I think we are going to keep saying this, but the existing spaces within HICPUF and the RAIs where Medicaid members are encouraged to be, we want to make sure that they have access to information so that they can go into those spaces and be telling the RAIs, this is how we want you to meet those contract stipulations. This is how we want to see it. And so I'll share a little bit later on of what we're doing around now through the go live date in July. But this just gives you an idea of where we plugged in along this journey. And this is it in Spanish, again, available in that PDF. Back to you, Samantha.
Thanks, Greta. The Connecting Food and Health project team didn't just reinforce existing conversations, it created new ones. We saw Medicaid members and health advocates alike asking, how can we be more proactive in addressing food access? It became clear that conversations around food and health weren't optional. They were essential to improving health outcomes, especially for those managing chronic illness. One of the significant outcomes was that the project team elevated food access as a priority within Medicaid and the regional accountable entities. It influenced how these organizations approached chronic disease management and created the foundation for more robust collaborations between healthcare providers and food systems. These conversations have led to broader policy discussions about integrating food access into healthcare strategies, a topic that has only grown in importance as we look at the long-term health of our communities. Reflecting on these gatherings, one of the most rewarding aspects has been asking fellow members for their feedback on advocacy work, particularly around projects like Connecting Food and Health. These conversations have opened new avenues of thought and given me insight into how deeply these issues affect each of us. For example, as we brainstormed how to better integrate food access with healthcare, we realized just how transformative it was to bring these discussions into spaces like the Medicaid MEAC and the RAIs. Our work sparked vital questions like, how can we better address food access in chronic disease management? These reflections not only deepened my understanding of community needs, but also empowered others in the group to engage in advocacy, knowing their voices were shaping the future of healthcare systems. Next slide, please. The consistency of the Wednesday gang has kept me grounded in these conversations. It's allowed me to stay connected to both the personal experiences of Medicaid members and the larger policy work we're advocating for. The learnings from these meetings have reinforced the importance of creating spaces for open dialogue where every voice matters. We've moved from sharing personal stories to collectively working towards solutions that benefit everyone, fostering a deeper sense of purpose in my advocacy journey. As a Medicaid member and advocate, one of the most challenging experiences has been navigating a system where everything feels siloed, whether it's food access, healthcare, housing, or transportation. These issues are treated as if they exist in isolation, when in reality, they all impact each other in significant ways. For instance, someone managing a chronic illness needs more than just medical care. They need consistent access to healthy food, reliable transportation to appointments, and secure housing to maintain their health. This siloed approach creates barriers for people like me and many others in my community. It means constantly juggling between different systems, trying to connect the dots ourselves because there isn't a unified approach. The lack of communication and collaboration between these systems is not only exhausting, but also detrimental to our health and well-being. It can feel like you're falling through the cracks even though you're seeking help. My advocacy work has shown me the importance of breaking down these silos, which is why projects like the Connecting Food and Health project team are so important. They demonstrate how food access and healthcare need to be integrated to truly improve outcomes, especially for those of us managing chronic conditions. When we approach these issues holistically, we create a system that supports people fully, not just in fragmented pieces. As we look ahead, as we look ahead to the ACC Phase 3, I'm excited about the potential to build on the foundation that projects like the Connecting Food and Health project team have laid. In many ways, Phase 3 represents the next chapter in how we approach healthcare, food access, and overall well-being. And it provides a significant opportunity to deepen the integration of these elements into our health systems. What I'm most looking forward to is how Phase 3 can institutionalize some of the ideas we've been discussing, specifically incorporating food access as a core part of chronic disease management and preventive care. We know that addressing food insecurity can dramatically improve health outcomes, and I'm eager to see how the RAISE and health providers can take that knowledge and apply it on a broader scale. This phase gives us the opportunity to advocate for food security, to be seen as a critical part of healthcare, not just an add-on or afterthought. One key area where I see room for growth is around data collection. As we continue to advocate for integrated approaches, it's essential that we have robust data supporting the connection between food access and health outcomes. This data can help us shape policies that prioritize food security and healthcare and make the case for funding initiatives that address these needs. My hope is that we can create an environment where food access is viewed not just as a social determinant of health, but as an essential element of effective healthcare. We can empower members to advocate for their own needs and ensure that they have access to the resources necessary for healthy living. Together, we have a chance to not only elevate the conversation around food and health, but also to implement meaningful changes that impact real lives. I'm excited to continue this journey with all of you as we work toward a healthier, more equitable future for our communities. And I'll hand it back to Greta.
Great. With the rest of our time left, I want to make sure that we bring the Department of Healthcare Policy and Finance perspective. So I'm going to have Tamara take us through that side because it's an important viewpoint of this advocacy. What you'll see on this slide is just what we're looking forward to at the blueprint. That includes supporting implementation of ACC Phase 3 and 1115 waivers. Always happy to connect offline to share more about what we'll be doing around here. But Tamara, off to you.
Thanks, Greta. So as a reminder, as I mentioned earlier, the Department of Healthcare Policy and Financing, also known as HCPF, is a state agency who oversees Medicaid in our state. And our mission is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. What I'm going to go over in our time today is first, I'm going to talk a little bit about the role that Medicaid can play in addressing health-related social needs, why we care about this space so much, and then talk kind of our perspective through the process that Greta and Samantha have already outlined with the ACC contract process. So next slide. So first, want to address the role that Medicaid can play in addressing health-related social needs, because I think there are a few different ways that Medicaid can play a role. So first, we can actually pay for services. We have the ability with Medicaid funding, for example, in our home and community-based service programs, already to pay for home delivered meals. And with new work coming up, so we've mentioned the 1115 waivers, this is really an opportunity for states to have more flexibility to pay for services that we don't typically within Medicaid authority have the ability to pay for. So for example, typically Medicaid cannot pay for a room and board, but with an 1115 waiver, that gives us the flexibility to waive that rule and allows us to pay for something like rental services. So we have the ability to pay directly for some of these services. We also work really closely with our other agency partners. So in Colorado, the Department of Human Services, that's our state agency who oversees the SNAP program. The Department of Public Health and Environment, they administer the state portion of the WIC program. These are partnerships that we're increasingly really interested in because we share members, right? Many of our members who qualify for our food assistance programs also qualify for Medicaid. And so we can work more closely to form relationships with those other agencies to make sure that we're most efficiently and effectively serving our shared members. We also can play a role in policy and priority setting. So in Medicaid, we are very grateful for our network of Medicaid providers throughout the state. And there are ways in which we can set priorities for our providers to achieve in the health-related social needs space. So an example would be we might incentivize providers to do activities like social needs screening. And that's one way in which we kind of pass down the priorities we have as a department down to providers and into our communities. We've talked a lot about the RAIs in this presentation. So again, those are the regional organizations who really manage the care of members at that regional level. And so in phase 3, as we've discussed, we have this emphasis on social need care coordination. So we can incentivize and require really those RAI organizations to make sure that they're including social needs and coordinating the care of members. So it's not just coordinating medical and behavioral care, but also making sure that members are getting those social needs met as well. And then finally, there's a role for us to play in data and analysis. So this is really, as the research manager, my role at the department is making sure that we're connecting data systems where possible. So we have some exciting work in Colorado right now on what we're calling the Colorado Social Health Information Exchange. So this is going to be a platform that allows for the sharing of social needs information across sectors. Samantha mentioned those silos that are really felt in this space. And so from the data side of things, we're excited about the work to try to break down some of those silos and share data outside of just the social care sector, but bringing that into healthcare. So again, we can most effectively and efficiently meet the needs of our members. Next slide, please. The other reason that we've engaged more and more in this space is because we know that Medicaid members are more likely to experience some of these social needs. So first, this slide is about housing security. This is data from a survey we have in Colorado called the Colorado Health Access Survey that's fielded by the Colorado Health Institute. And in their survey, they found that for Coloradans with incomes under 200% of the federal poverty level, 20% said that they had problems paying their rent or mortgage. And so we know that our members are more likely to experience these problems. We also know that there is this really clear tie between experiencing these social needs and health outcomes. So the survey found that Coloradans with unstable housing are nearly 3 times as likely to report poor mental health as those with stable housing. So among those with unstable housing, almost 63% said that they were experiencing poor mental health compared to 22% of those with stable housing. On the next slide, I have similar data on food insecurity. So statewide, 11% of Coloradans said that they ate less than they should because they couldn't afford food. And when you look at those with incomes under 200% of the federal poverty level, it was almost double at 19.7%. So again, just wanted to emphasize, we know our members have these needs. And so that's really why we're increasingly invested in finding ways that Medicaid can play a role in addressing them. Next slide. So specific to the contract drafting process, just from our perspective, so when we approached phase 3 planning, we did have this intention to focus on social needs, but we recognized that we lacked the expertise. So we're a healthcare payer. We have a ton of expertise in Medicaid and the healthcare system, but we knew that we would need input from the experts on housing, on food, on those social needs. So we solicited input from the stakeholder community for ideas on what would be an appropriate role for the raise. And that's when Greta is talking about and Samantha talking about the letters that were sent. That's really how we got that input. So we went back and forth with the community, and it was really helpful to have coordinating organizations here to send one letter rather than receiving 18 different letters with different ideas, phrased slightly differently from different organizations, to have a coordinating organization who could really send us one letter representing the viewpoints of the different food advocacy groups. That was really helpful for us. We went back and forth to really fine tune that language. Next slide, please. So just some reflections on why I thought that process was really successful from an agency perspective. From the letter specifically, the groups included really well-cited evidence. And I think this is something we see a lot in the outreach we get from advocacy groups, is there's data included, but oftentimes it's not well-cited. It's not really clear where the information came from. And this letter contained really well-cited evidence that made us comfortable in believing that the data that was being cited came from somewhere reputable, and then it really helped bolster the case. The second highlight is that their letter called attention to the specific sections of our contract and provided recommendations within that structure. And I think that highlights 2 big points. One is it showed an understanding of what we were working with and what would be possible. And then it honestly administratively just made it a lot easier for us that they had gone through and done the work of thinking through how this might fit in. And it made the conversations from the agency side just a lot smoother. And they also cited other state-specific contract language. And so it almost showed us this is possible, this is happening in another state. And that made it a lot easier for us to think about how that could work in Colorado. And then overall, as I've mentioned, they just demonstrated a solid understanding of our program. Another reflection that I had in thinking through what made this successful is I think, it's important to recognize that state agencies do have barriers to implementation that often we have a really difficult time overcoming. So we have federal regulations, we have state regulations, and of course, there's so much we can do within the confines of those recommendations, but we often are up against regulatory barriers that can make things difficult. And so I think this next point of it's important to state your goals and your values so that if it's not possible for us to meet all of the needs, again, because of those barriers, we can see what the intention is and where you're trying to go. So that makes it easier for us to offer options or alternatives of how we can get there together. And I think that was my last slide, so I'll turn it over to Greta.
Great. Thanks, Tamara. So just to wrap us up with some final reflections, and then we'll have some time for questions, which is great. I already see one that I'm going to have Tamara take. But you know, from the coordinating organization and being a collective impact organization, where I've said it a lot, but we really care about creating shared meaning. And the only way to do that is through making sure information is accessible, making sure spaces of power and decision-making are accessible, so everyone can share their input and have an impact. So with, again, food is medicine versus food is health, I think food is medicine. And I also know that food is health. And so making sure that we are looking at these population-based nutrition and food access programming, making sure they're strong in our state. When, you know, there's a lot of really neat, fun programs that states can invest in, particularly through Section 1115 waivers. And I just want to make sure that we're being creative in how can we also use those waiver flexibilities to support general, robust food access for members. Samantha spoke a lot about this from the Medicaid member perspective, but data sharing and cross-program alignment. I think we talk about this a lot in the food space anyways, in terms of reducing administrative barriers, not just for folks eligible for these programs, but the folks implementing these programs. This has to do with not only how a state interprets federal guidance, but how federal entities are supporting states in exploring that. This takes infrastructure, this takes time. And so as an organization, it is one of our priorities to just support how do we make these programs more accessible and not make it so many separate doors have to be walked through to access. And then lastly, again, my biggest reflection is just resourcing was huge. And I use resourcing broadly. That's with knowledge, access, funding, and infrastructure in order for community members, decision makers, and community-based organizations to all come together and create a shared vision for food and health in our state. And so with that, I want to thank you all so much for being here. I'm going to stop sharing my screen. And then we can go to questions and I can field them. So feel free to put them in the chat. But Tamara, one question we got from Colleen was, in terms of coordinating care for members, are the RAIs mostly local social service orgs?
Thanks for the question. So no, there's a mix. So we have some RAIs who are part of larger health insurers. We do have some who are homegrown Colorado-based organizations. They're not social service organizations. Really, the mandate for the RAIs is to ensure that care coordination happens. And so that looks a few different ways. So the RAIs all have their own care coordination staff. So they have nurse care coordinators. Some of them use community health workers. Some of them are using social workers. So they have their own staff. And then they delegate care coordination down to primary care providers. And then there are some RAIs who use a model where they are co-locating in the community and do have that connection to the social service organizations. And for phase 3, we're interested in kind of that last option of we're interested in seeing how they do more embedding into the community. And that's really in response to our call that they have more of a focus on addressing social needs. And so because of that, we do hope to see some more of the co-location in the social service organizations. But in general, it's really mostly they have their own care coordinators on staff, and then they delegate down to the primary care providers.
Thanks, Tamara. We also got a question in the Q&A feature from Ray, and I took like a really overly simplified approach to answering your question, Ray, so I want to dig into it a little bit more. But the question was, what are the data points to help define the relationship of healthy food on well-being? the variables used, uniform guidelines, and supporting that across various programs like Meals on Wheels to medically tailored meals. And I did share, I would really recommend taking a look at the large recommendations document that I uploaded that was provided to the department. Tamara spoke to how we cited a lot of the research and outcomes. But I can also share a lot of this is just tied, I think of programs like WIC. They demonstrate clearly through that program how it reduced healthcare costs, for Medicaid members and the healthcare savings of families participating in WIC. We have similar findings for SNAP. And I can also speak to, from a dietetics perspective, there's a lot of evidence of just increased healthcare costs when folks are malnourished and what that does to readmissions into hospital settings and just like chronic disease outcomes. So I guess what I would say is I think there's a lot out there, and depending on the message and values you're trying to get across, there is evidence of those, and there could be more too. And I think that's a call as well for advocates on this call, is to make sure we're making those connections explicit. But Tamara, I don't know if you had any takeaways for Ray on any specific data.
Sure. I think in addition to what you've already mentioned, we are typically looking at, for our members who have been hospitalized, we're looking at outcomes around rehospitalization and the impact that access to nutrition and nutritious foods can have there. And so I'm trying to think kind of more on the acute end of things, really looking at members with chronic health conditions. So a lot of the guidance from CMS, so from our federal partners, is really focused on members who have a chronic health condition. And so they're interested in looking at things like readmissions as one of the main, like you're asking about variables, and I'm thinking kind of really tactfully, it's readmissions, it's A1C, it's really trying to understand the impact on members who have these diet-sensitive conditions, and that's the language you typically see from our federal partners. There's nutrition-sensitive conditions, diet-sensitive conditions, and then some states have actually focused specifically on the postpartum population, pregnant and postpartum, as another area of interest. And so I agree. I think the literature that was cited in the letter is a really good place to start to understand what some of the big talking points are in the literature around this. So thanks for the question.
Thank you, Tamara. I went ahead and updated. It's a pretty big file, so I hope it got into the chat. What I'm also going to do, knowing that we have less than a minute, I'm going to put my email into the chat. And if you have questions for Samantha, Tamara, I am happy to coordinate them. But just that way you have one email and you don't have to worry about remembering who of us was talking about which. But if anyone wants to connect, we'd love to have you. You're also welcome to come to one of our project team meetings. We're going to kick them back off in January. And we welcome anyone who wants to try to replicate this. So thank you all.